We present a case of transvenous embolization of a cervical arteriovenous malformation with transvenous cardiac pacing. This case involves a female in her 50s who had sudden onset neck pain that radiated to the right upper extremity with associated weakness, in which patient was 3 out of 5 proximally and 1 out of 5 distally in the right upper extremity, as well as mild 4 plus out of 5 weakness in the left upper extremity. Initial CT imaging demonstrated a intradural as well as intramedullary hemorrhage with hypervascularity along the dorsal aspect of the hemorrhage and spinal canal. MRI cervical spine imaging demonstrated moderate edema in the cervical spinal cord, as well as associated GRE and T2 hyperintensity and cord signal change, noting the acute hemorrhage. Initial diagnostic angiographic images with a right vertebral artery injection demonstrated a cervical spinal cord arteriovenous malformation, primarily effect from the cervical C3 and C4 radicular arteries, with an early draining vein along the dorsal aspect of the cervical spinal cord. Patient also had an underlying left subclavian artery occlusion with left vertebral artery steal. After extensive discussion, it was decided to treat this cervical spinal cord AVM with a transvenous approach with cardiac pacing. After obtaining right radial artery as well as right jugular venous access, a guide catheter was placed in the right vertebral artery. Afterwards, an 8-French track star guide catheter was positioned in the right sigmoid sinus, and utilizing an Eclipse 6 by 12 millimeter balloon, a headway dual microcatheter over a synchro-standard microwire was navigated through the right superior petrosal sinus into the dorsal cervical draining vein of the AVM, and further navigated down the draining vein immediately proximal to the cervical spinal cord AVM nidus. A second Apollo microcatheter with the detachable tip was further navigated into the cervical dorsal draining vein of the AVM. Afterwards, a coil was deployed in the distal cervical dorsal vein, as well as additional coils in the proximal cervical vein that was draining the AVM to perform the pressure cooker technique. With the Apollo microcatheter at the draining vein at the nidus of the AVM and the headway dual microcatheter in the proximal cervical draining vein adjacent to the coils, NBCA was injected to the headway dual microcatheter to form a proximal plug, and then Onyx 18 was injected to the Apollo microcatheter with good penetration into the AVM nidus, with all embolic material injections done under cardiac pacing at intermittent intervals to maximize penetration into the AVM nidus. Final angiographic arterial injection through the right vertebral artery demonstrated complete obliteration of the cervical spinal cord AVM with no further early venous drainage along the dorsal cervical vein, which has now been embolized. Patient did well post-procedurally and had mild improvement in her left upper extremity strength and is now pending rehabilitation.